Great.
So most of the credit goes to you. So
Thank you.
forgive me if I stumble. I'm straddling the edge of lucidity and delirium here. So I may need help.
I guess we could have done you another day, but you already started, so that.
But that's okay. I didn't get to present last month.
Oh, that's right. Yeah, I underlined you, which means you're a carryover. Okay, oh, who's going to discuss it? Is this kind of a harder one? I can't remember.
I don't think so.
Shoot.
I mean, it's not a diagnosis I was familiar with.
Okay, we'll have Sabrina do it then.
Okay. 27-year-old white female, no insurance, vision in the right eye started getting worse in October 8 months ago, and it's continuing to get worse. The left eye is fine. When she looks directly at something, there is central glaucoma. Some days is darker than others. She had a cold last month. Prior to the vision loss, she did not get sick. In 2013, she did mission work in Honduras and went on a cruise. She gets occasional knee pain and seasonal allergies. She has a cat. This is an old household cat. There's migraines. Her vision is 2200 on the right, 2020 on the left, with normal pressures and no color images.
Oh, yeah, sorry about that. I'll try to get colors, but.
Okay, so we have the IR with the right eye showing some hyper-reflective material, kind of superior nasal to the disc.
Yep, that's exactly right. There's some scattered areas of reflectors.
And then an IR of the left eye is normal.
I'll be showing a number of left eye images. Some of them are going to be normal, and I'll just jump ahead to qualify that they are normal for the sake of time.
Then we have autofluorescence of the right eye. So there's a lot of hypoautofluorescence in the macula and in the area where we saw the spots on the IR. And then in the macula, I think there's like a subtle hyperautofluorescence that's kind of like mostly inferior and like a heart shape, and then like a speckle of brighter hyperautofluorescence.
Yep, it's great.
In that pattern, just to jump ahead, but the pattern you're seeing, that circly one, the big circly one, is pretty common. It means there's either some outer retinal atrophy there or cirrus detachment. That's kind of in the shape of what you would expect was either a current or past cirrus detachment that either did some damage to the photoreceptors or left some fluorophores? I guess things that would fluoresce, like outer segment. But
and then left eye, no, maybe superiorly there are tiny little hypoautofluorescent spots, but otherwise, I think the hyperautofluorescent one inferior to the nerve is FA here. It looks like we're past the AD phase, probably a little bit late somewhere, but the bottom says autofluorescence.
Yeah, that's the staff doesn't push the thing.
Oh, okay.
Drives me crazy.
So we have some hyperfluorescence,
Sorry.
nasal, supranasal, and superior macula.
And then there's a hyperfluorescence area with a dark spot around it. You see that?
Yeah. That's
kind of important. That pattern is meaningful when you get bright and then dark at the edge.
This is again the right eye just shifted immediately, demonstrating more of those lesions. And again, redemonstration.
Yeah, and so far, that looks a little bit more like weak range. I was gonna say so far they kind of have.
Yeah.
But now that looks like it's.
Here's the left eye. Again,
Normal.
relatively normal.
And the right eye ICG. So there's some hypofluorescence.
Good.
In the macula, and that same dark spot that Dr. Cohen pointed out that had the hyper with the hypo around it on that FA, and then the same like supranasal spots. are all hypofluorescent on the ICG.
More ICG.
It's just like a super late ICG.
Pretty late,
Super early.
Yeah,
16, 19 minutes? No,
Okay.
yeah, that's what I thought.
8
Okay,
minutes,
thank
8
you.
minutes.
Oh, wait.
And then left eye, ICG.
Looks pretty normal to me so far.
Okay. Now we will get to.
Okay, so it looks like an IR photo on the right, and then an OCT, oh, sorry, on the left, I need to know that. On the left, and then an OCT on the right, so there's like this subretinal hyperreflective material that looks akin to some fibrotic scars that we see. But otherwise, the inner retinal layers on top have good integrity, they're normal.
Do they? Where's the outer retina?
The outer retina is lost, the inner
Yeah,
retina looks
Inner
good.
retina looks good, yeah.
Just additional demonstration of the same.
Mhm.
Further demonstration, and now
And even in the areas where that, you get the chunky hyperreflective scar looking thing, but then on either side of it, you still had loss of like the PR kind of, and like the ellipsoid
And that's where you had that halo. Remember the halo on the autofluorescence?
um,
That little area, there was a
Yeah.
bright spot and then the halo. That was from the loss of some of the outer retinal layers. So this is kind of the end of the beginning presentation, right? She comes back later. Isn't the next color later? When's that color picture? What date is that? I don't know the date on it.
I didn't have a date, unfortunately.
All right, so what do you think's happening before this one? From the prior pictures?
so she has something that's leaking and causing outer retinal damage, loss and scarring.
Right?
Um. Also looking,
Yeah. Well, what's it look, I mean, if you see that, what's that look like there in the color?
it almost looks like what a pre-retinal membrane in diabetes would look like, but it's under the vesicles.
It's kind of like, it's sort of a scar. It's kind of like a scar. So, and then, so she's got the leaky thingy, which is sort of like fibrovascular scar. And then what about all the spots? So there's kind of two things going on.
These are not visiting symptoms, but they're hypopigmented spots.
Good.
And if,
And how big are they about?
like an eighth of the disc diameter.
So they're kind of small, 200 microns, maybe 3. They're not 800 or 1,000 microns on it. I mean, there's some variable ones, but they're mostly kind of smaller pigmented spots. And then there's that thing growing out of one of them. So that's good. So you want to keep going? We'll see what the rest of the pictures are.
No,
Left eye.
Yeah.
my left eye.
And how old's the patient? I can't remember.
27.
No,
20.
27. Oh, yeah, she
Yeah.
was 27.
27.
This didn't happen overnight.
So the summary of the findings we have here, so on the IR, yeah, there's the validators of hyperreflectance, and then hypoautofluorescence on the autofluorescent pictures. You mentioned hyperintensities corresponding with the above, foveal hypoperfusion. Hypofluorescence on corresponding with the above, OCT with hyperintensity and RPE choroidopathy. Also known as unpigmented restriction, focal areas of what I thought. So she's young, I feel like it's probably something inflammatory.
Good.
I don't know if like a pic would look like this with the white spots, it doesn't look like news.
Yeah, we were just talking about David, because you've got PIC as multifocal. So you got multifocal spots in one eye, which is kind of PIC. And then there's the multifocal choroiditis with panuveitis, which I don't think is on your list. And then there's
This
this subretinal fibrosis syndrome,
Yeah.
which may be all,
related to
yeah.
late stage of any of these.
All right, so go ahead with your list.
It's unilateral. It's probably not mutes because mutes is evanescent.
Yeah.
Yeah.
It doesn't look like.
Yeah.
And on the autofluorescence, all the spots would have been brightened.
If it was active,
yeah.
correct, mute is always activated. Yeah.
Could you say that again, Sabrina?
Oh,
The autofluorescence box would be bright with me.
Okay.
If it was.
right. And it was not active, they should be gone, right?
Active ones often block early, stain late.
No, mute.
Not mutes on like other ones.
Yeah, other stuff, yeah.
Other things.
And mutes, the spots are bigger, and then they classically have that read thing,
Read like a
which
bear.
is kind of the sort of.
Read the.
Okay, cool.
Go ahead, David.
So the diagnosis here was PIC.
But you probably could have spread, so this is probably PIC, but there's also multifocal choroiditis, and then there's also this subretinal fibrosis syndrome, and but there was only one. If you go back to the picture with the scar, I think there was a second one, sort of nasal, wasn't there? Yeah, so there's that one, but then you got the second one superiorly, and then you've got this peripapillary stuff. So it's so it gets to be a lot of fibrosis for PIC. I mean, PIC, you look, so I thought this was a tough one. So you have to kind of put your cards on the table, your money down, whatever the expression is. I still can't come up with it. But so I would call this PIC, but you could very easily say multifocal choroiditis with subretinal fibrosis, which is kind of a nasty syndrome. All right, so keep going though, but talk about PIC. I like PIC.
So in this particular woman, Lucentis was started, her vision improved but fluctuated, and the scar would continue to increase over time. Do you have additional follow-up on her? Do you know if it's resolved?
Oh, is that all I sent you?
Mhm.
Oh. Yeah, I think I do. Her vision, freakishly, I think her and several patients of mine like this. We stop treatment, they've got a big scar, and then their vision's weirdly good. So I think this patient's vision actually did end up being like even off treatment 2050 or 2040 with a big subfoveal scar. I'm pretty sure this is the lady I'm thinking of, because she was pregnant at one point, and then her grandmother just died, and her grandmother paid for exams and the whole project. But or she was trying to get pregnant, lost the baby, so we stopped her treatment for a little while. But I'm pretty sure that even without treatment, she ended up actually with pretty good vision. So yeah, that's all I have.
And how long does it take for that subretinal scar to develop?
It can be really quick. It's really, I don't have a lot of the scarring ones. I've probably seen fewer than 10. And I had one lady with one eye, and she did a weird thing. She was true subretinal fibrosis, where she came in, I was treating her. I probably didn't have her uveitis as controlled as I should have. In retrospect, it's easy. She had a non-macular scar, and then she came in, I think, a month or two later with a big macular scar, which looked honestly like it had just formed from the RPE. It didn't look like a blood vessel growth. It looked like the scar just appeared, which was strange. So the subretinal fibrosis ones are truly weird.
Okay, so just some additional learning about PIC. You'll see.
Yeah. Go ahead. Listen.
Typically, it
We're
presents
gonna
by
send an ambulance to your house if you stop talking.
You
sound terrible.
What are you sick with? Do you have the codes?
She got back from the academy, so.
Yeah, I have post AAO syndrome.
Oh, post A, yeah. That's it. Yeah.
I went to the urgent care, COVID and flu negative, but I have some more tests coming in the mail today.
Yeah, you're still hungover. You'll get better tomorrow.
It's a long hangover.
Yeah.
And the first time I had a febrile hangover. So typically it presents bilaterally, but will present asymmetrically. So in this particular case, it was certainly asymmetric. Maybe some early changes that we saw, but this fits in pattern. She's also right in the middle of the typical age group. She was, I think, 27. And what you see are these deposits between the inner RPE without vitritis, and just here's a selection of her OCT, again, just to demonstrate exactly that. It wants to move forward. Okay. Just a summary of the retinal imaging findings that you would typically see. Well, early or earlier, can't remember what I wrote, hyperfluorescence with variable leakage in the staining. You'll see more leakage if there is a neovascular membrane. On ICG, you see the mid-phase hypofluorescent lesions, and OCT, the focal hyperreflectance and elevation at the RPE that we see here. The treatment for this is somewhat varied. What I was reading is that they didn't typically suggest any treatment unless there was a neovascular membrane. Excuse me. You can try systemic immunosuppressives, steroids, mycophenolate and sirolimus. You could do intravitreal injections of steroids and anti-VEGF. And you could do PDT if there was CNV. The prognosis is relatively good, as this woman sounds like she experienced. Unfortunately, it looked like she did have choroidal neovascular membranes, and those will typically present in 2/3 of the cases. These are my references.